Okay, sir. So we will move on to our next topic for today. For the next topic, we have Dr. Ashwin Kumar with us. He is consultant surgical oncologist at Manipal Comprehensive Cancer Center, Manipal Hospital, Bangalore. He has done various clinical fellowships on various breast-related fields from the international hospitals. His field of expertise are surgical oncology, robotic surgery, breast conservative surgery, and oncoplasty. He has got many awards and achievements in this field of breast surgery. He'll be delivering talk on early breast carcinoma. I would like to invite Dr. Ashwin for his talk.
Hi, can you see the screen?
Yes, sir.
Great. Hi, thanks a lot. So my talk for today will be early breast cancer. How do we proceed with the treatment? So this will be like I mentioned, the ABSI module. So what is early breast cancer? The definition is it includes, according to the AJCC 8th edition, it includes both stage 0, that is ductal carcinoma in situ, and stage 1 and stage 2 cancers. It is interesting to know that lobular carcinoma in situ is no longer classified as in situ disease. It is seen as a pathological precursor. So if it is the treatment of lobular carcinoma in situ is completely different. But I'll be covering mainly ductal carcinoma in situ stage 0 and treatment of early breast cancer, that is stage 1 and stage 2. Another interesting fact of AJCC 8 staging is it is also not only anatomically broken down, it is also biological types of cancer. It's very, very important to know that each type, pathological type, that is luminal, HER2/neu, or triple negative breast cancer, the treatment guidelines are changing. That is, the treatment for luminal is different, HER2/neu different, triple negative breast cancer. So now we have found out that the pathological prognostication and the treatment is completely different. So for any early breast cancer, like for a breast cancer, the diagnostic workup is take a proper history, then do a proper clinical examination. Always do a core biopsy, never an FNAC for the primary. But if you have any suspicious nodes, you can do an ultrasound guided FNAC of the lymph node. The metastatic workup includes basic blood tests such as CBC, LFT creatinine, chest X-ray, and ultrasound abdomen pelvis. PET scan in early breast cancer is usually, or bone scan is not routinely recommended. So what is the treatment for ductal carcinoma in situ? The first aspect is surgery. So it can either be a lumpectomy or a breast conservation surgery or a mastectomy. Sentinel lymph node is not routinely done in ductal carcinoma in situ. The only two indications that we do is if we are doing total mastectomy, we recommend that we do SLNB, or if there is high grade ductal carcinoma in situ, in those cases also we would recommend you do a sentinel lymph node biopsy. So after the treatment of breast conservation surgery, the treatment for ductal carcinoma in situ includes radiation therapy. Usually a hypofractionated radiation therapy is usually can be done, or conventional radiation therapy. Now there are studies are showing that even for low grade cancers with a good margin and if they're ER positive, radiation can also be omitted. Tamoxifen, like adjuvant treatment, if they're hormone positive, please give tamoxifen, or you can give aromatase inhibitors. This is the treatment for ductal carcinoma in situ. What is the treatment for early breast cancer? First, I'll be going step by step. First, I'll discuss about surgery in detail. Then adjuvant chemotherapy, different types of radiation therapy can be given, and of course, hormonal therapy. So this is a brief algorithm given by the ESMO guidelines regarding how to treat an early breast cancer. Like I said, it depends if it's a T1 disease, T2 disease, N0, or N1 disease. So the first aspect of primary treatment for early breast cancer is breast conservation surgery or mastectomy for the primary. For the axillary lymph nodes, if it is clinically N0 and if you have the expertise, please, the gold standard right now is sentinel lymph node biopsy. But if you don't have the central lymph node, what all require like the frozen section or the dye, you can still do axillary lymph node dissection, or if it is an N1, you can do axillary lymph node dissection. Coming to the first primary treatment, mastectomy includes a simpler or total mastectomy. You can do in sometimes, that's the most common that we do, or you can do skin sparing mastectomy, or very rarely, if the disease is away from the nipple area or complex, and if it is less than 3 centimeters, you can do a nipple sparing mastectomy with reconstruction. Usually we prefer immediate reconstruction to all the patients. Only exception to not do a reconstruction after mastectomy is an inflammatory breast cancer. And obviously the reconstruction techniques depends on patient to patient. It can be autologous or it can be an implant. Coming to the surgery, this is the old method that we were doing. That is, more radical, the better. That is, before we were doing radical mastectomy where all the structures were removed, the pectoralis major, pectoralis minor, level 1, level 2, level 3 lymph nodes. Then we went on to the modified radical mastectomy where we could save the muscles, that is pectoralis major or pectoralis minor. But all these was before the era of Bernard Fisher. Now we have found that there is now in early breast cancer, it is not necessary to do a radical surgery. Just by doing radical surgery does not mean the treatment is better, does not mean the recurrence is lesser, does not mean survival is better. Now we are going from the era of maximum surgery to doing minimal tolerable surgery with the same benefit. So this is the era of breast conservation surgery. In Manipal Hospital, we offer breast conservation surgery to almost 80% of the patients who come with early breast cancer. Only few patients, because of either a contraindication of clinical nature, or if they have financial constraint, or if they don't prefer, only then we prefer mastectomy. But we always recommend that if they have the correct indications, we encourage them to go for a breast conservation surgery with oncoplasty. So this is an interesting where Bernard Fisher is one of the pioneers who started this whole idea of conservative treatment by doing a lot of research. He was a chair of the NSABP. So it's a very interesting history of the way the amount of resistance that he had, the amount of problems that he faced. It's a very good read. I recommend all students to go through his history. So now we have to decide not only giving a good oncological outcome, a cosmetic outcome for a lady is also very, very, very important. So what is breast conservation therapy? The breast conservation therapy includes 3 parts. One, for the primary, we do what is called as wide excision of the primary. There was a lot of issues about what is the ideal margin. Some people were removing 2 centimeters, some people were removing 1 centimeter, and some later it came that a 2 mm is enough. But right now, according to current recommendations, a no negative margin, that is pathologically, if there is no cancer on the margins, we can say that it is enough. Even focally positive can also be accepted as long as you give a radiation boost. Next is the axillary nodal surgery. You can either do sentinel node biopsy if it is N0, if it is N1, do an axillary clearance. The most important part of breast conservation therapy is all the patients who undergo breast conservation surgery need radiation. Boost might be required based if it is a higher risk disease, which I'll be discussing later. So the main myths that is still very prevalent, not only among the public, but also among the surgeons, is that breast conservation surgery has a higher recurrence, which is not true. It's been proved with 20 to 30 years of follow-up that the recurrences are similar to a mastectomy, and also survival is also similar. How do we know that? Is by the large amount of evidence that we have, level 1 evidence. The first trial was NSABP 06, and the largest trial is the Milan trial by Veronesi. It has proved that BCS is as good as mastectomy for proper patients in the early breast cancer. What are the advantages? Breast cancer, it is the most important is the better quality of life. The ladies are psychologically have a better body image and have a better self-esteem. So what are the indications for doing breast conservation surgery? It is either T1 or T2 tumors we can do. Anything more than 5 centimeters or more than 4 centimeters is also acceptable as long as in the large breast. What are the contraindications? Some like prior radiation therapy, if it is a multicentric disease. During surgery, if you're getting continuously positive pathological margin, or if it is extensive skin involvement or inflammatory breast cancers, or if the patient prefers a mastectomy, these are the contraindications to do breast conservation surgery. The most important is breast conservation pretty simple as long as you follow the proper principles. The first and foremost, like I said, the margins. The margins is pathologically you should not find any tumor on the ink surface. As long as you get the proper margins, that is all-round margins, the 6 margins are negative, that means the surgery is complete. What are the standard procedure? Incisions depends on you can either take a circumareolar, you can take a radial incision like Dr. Vijay had explained that extensive presentation. You can take different incisions based on the cosmesis. You don't need to take a skin. It is not a must. Lumpectomy cavity. Sometimes we can leave a seroma, but some surgeons, our plastic surgeon, in fact, doesn't like a seroma. He says that it's better to put a drain. The cosmesis is better. It depends on the institution. And always, because the radiation is required, always put the titanium clips so that we can radiate the proper lumpectomy cavity. In case there are, just because a lady with a small breast comes with a large tumor, you should not tell her that breast conservation surgery is not possible. In that, if they are having HER2 positive or especially in triple negative breast cancer, the latest guidelines say to give neoadjuvant therapy, or if it is a large tumor and still we can still provide the patient with breast conservation surgery by doing level 1 or level 2 oncoplasty, like what was explained by Dr. Vijay. There's a algorithm for how we do breast conservation surgery, and always remember the negative margin according to latest guidelines is no ink tumor on the margin. So these are the guidelines which is saying that MRM one or mastectomy one compared with BCS, the 20-year follow-up data found that the survival is the same, DFS or OS. These are again the landmark trials, multiple trials, which is we have enough evidence to, so any patient, any person asks that is BCS is equal to mastectomy, yes, as long as you do proper surgery and as long as you do as long as you give radiation with or without a boost. Coming to how do we manage an axilla? So in usually early breast cancer are come with T1 N0 or T2 N0. The gold standard treatment at present right now is sentinel lymph node. So this is a patient who underwent a total mastectomy, and you can see this is the axillary clearance which was done, level 1 and level 2 lymph nodes. But the biggest problem with axillary dissection is lymphedema, which is almost common in 15 to 25% of the patients. They can have paresthesias, anesthesia, restrict shoulder movement, especially when you do level 3 clearance. They can have, since it's an extensive surgery, they'll have a lot of seroma formation and also have higher morbidity and always chance of lymphedema later. Descriptive picture. Now, sentinel lymph node biopsy for an axilla is considered as good as axillary dissection. It is efficacious, that is clinically, oncologically, it is similar to axillary dissection, and it is more cost effective and also have decreased less morbidity. Even now, not only we do it in our hospital, do we do it in axilla, that is N0 axilla, even after even if they're N1, after neoadjuvant chemotherapy, there are enough evidence to say that sentinel lymph node can still be applied for those patients also, although it is the level evidence is maybe level 2 or level 3. So with proper training, with using dual dyes, we have found that evidence found that the identification rate of the metastatic node is 97% with very, very minimal false negative rate. So this is the pictorial concept of sentinel node. What is sentinel node? It is the first node that the tumor usually affects. That is, we found that the cancer in the axilla spreads in a stepwise manner. That is, it affects the level 1 lymph nodes first, and later it spreads to the other lymph nodes. So if we are able to find a sentinel node or the first lymph node that is affected, if it is negative for cancer, that means the other higher level lymph nodes, if being affected, is very, very, very low. So how do we do that? We in our hospital we use a dual dye or even sometimes a triple dye technique, but we have found that dual dye is good enough where the identification rate is 97%. So we inject the dye. It can be either a blue methylene blue dye, or it can be indocyanin green dyes, which is a fluorescent dye, or it can be either a technetium dye. So either two combination is injected either in the around the tumor, or more effectively what we do is we inject into the plexus of Sapi. Once we inject the dye, after the patient is induced under anesthesia, we give a massage for about 3 to 5 minutes towards the axilla, allow time for the dye through the plexus of Sapi to go through the lymphatics into the axilla. Once this done, we either during BCS we put a separate incision in the axilla. We identify the blue color dye as you can see here, and we dissect 1 or 2 lymph nodes and we send it for frozen section. The pathologists in our hospital do a frozen section in 20 minutes. They're able to accurately give if the metastasis has spread to the lymph node. If there is metastasis that is macro, that is greater than 2 mm, we go ahead and do an axillary dissection. So this is a concept. And we have found that the accuracy of sentinel lymph node biopsy by various trials, the Varanasi, Almanac, the Sentina, SNAC trial, that the SLN identification is more than 98%, and false negative rate is almost less than 5%. Again, with respect to the survival, everybody is worried. Ultimately, everybody wants the cancer to be treated. Oncologically, we have found that SLNB or axillary lymph node dissection, the recurrences are similar. It is not statistically different. Disease-free survival is also similar, and overall survival is also similar. So why not do a minimally invasive sentinel lymph node and give less morbidity than do an axillary dissection? We have found that when we have evidence that the clinically or oncologically it is similar. So once we do the surgery, then we go for the adjuvant chemotherapy. This is just a brief algorithm. Again, like I said, now we are in the age of the biological differentiation of the cancers. So luminal A depends on luminal A or luminal B. We always find out what type of recurrence. If they're low risk, we just give endocrine therapy. High risk, we need to give them chemotherapy. Again, all this will be discussed later tomorrow when the doctor on the presentation for adjuvant chemo. If it is triple negative breast cancer, we in our hospital or Hertinu, in our hospital now, we prefer to give neoadjuvant and then operate. And after that, based on the risk scaring, we give them adjuvant chemotherapy. Radiation therapy. In ductal carcinoma in situ, the radiation is given to all patients who undergo PCS, and boost for radiation therapy is given if a higher risk or for local recurrence based on the pathological factors like comedo type, or if the margins are focally positive, or if there is a higher grade. Now, conventional radiation, now with accelerated partial breast radiation can also be given. The main, logic behind it is that the recurrence happens in the area around it. That is ipsilateral breast recurrence. So there's no need to give conventional radiation for low risk patients. So ladies more than 50 years old who have unicentric, node negative, if it is a tumor is less than 3 centimeters and hormone positive, these are the low risk group. You don't need to give them a 4 week or 6 weeks of radiation. If we can give them 3 weeks of accidental breast radiation, or in fact, even sometimes we give hypofractionated schedules also. So this is the algorithm for radiation. All patients, again, who undergo breast conservation surgery need radiation with or without boost. Mastectomy patients usually, if you do in early breast cancer, do not require any radiation. Only indication is if it is T3 tumors, young patients with high-grade tumor with lymphovascular invasion, and obviously if they come with lymph node positive. Sentinel node, again, like I said, for ITC, we don't need to give radiotherapy. If any micromets or macromets, we consider them a node positive and we give them radiation therapy. Coming to the conclusion, yes, early breast cancer, although less uncommon in India because most ladies come little late, we have found that with better screening methods, with better awareness, ladies do come with 1 and stage 2. It is imperative that all the young doctors know that breast conservation surgery is easily possible. We have got 20 to 30 years of evidence with our own Manipur hospital having from the last 20 or 15 years doing about 70 to 80% of patients undergoing breast conservation surgery, that it is possible. Always be aware of what are the different methods, know when to do, what are the indications to do, when to use neoadjuvant therapy, and always it's good to know how to perform sentinel lymph node biopsy, because it is all you need is a frozen section, and easily you can get the blue dye. It is not very expensive now, especially with the different companies coming forward. It is a multidisciplinary team. You need a good imaging specialist, you need a good medical oncologist, pathologist especially, and radiation oncologist too. Thank you.
Thank you, Dr. Ashwin. It was really a nice and elaborative talk on early breast cancer. And our students were quite benefited with that because they are now knowing the exact approach with which such type of cases should be dealt with. So now coming to the last session for part of today's session, that is the concluding remarks. I would like to appreciate that Dr. Rohit for a very well explained explanation regarding growing problem of breast diseases in Indian scenario, and the screening pattern and techniques which were very nicely explained in his talk. Dr. Anjali covered every aspect of triple assessment in details. It was an eye-opening talk on this topic, and I think most of the queries of our postgraduate students regarding triple assessment were cleared very nicely. Dr. Vijay highlighted all the perspectives of oncoplasty in details, and an entirely new world of oncoplasty was introduced to the audience today. I would like to extend my thanks to Dr. Ashwin for enlightening the audience on details of early breast cancer in view of diagnosis, evaluation, and management, and also a very detailed talk on BCT, which is must for today's world. Coming to the end, I would also like to thank the audience and all the participants for their active participation. There is one reminder at the end that you all are invited for tomorrow's session, that is second day of our ABSI module. It will be on 28th, that is tomorrow, 2 p.m. onwards, and the link of tomorrow's session is already shared on the brochure. So looking forward for participation of all the delegates tomorrow, and we'll meet again tomorrow at 2 p.m. sharp. Thank you, everyone.